Hello, myself Dr. Sanjay Khatri, your pediatrics faculty at Medway. Yes, I try my level best to give you the best of concept of pediatrics that will help you to crack your exam. Pediatrics, there are so many important topics. Some belong to real pediatrics and some overlap with medicine. So most important topic in pediatrics from my side is neonatology. Lot of questions are coming in various exams. So yes, we start with neonatology. So neonatology, the first basic definitions. What is neonate? From birth to 28 days is neonate, and study of neonate is neonatology. Now, when we use the word term, a baby born between 37 to 42 weeks, it's a term baby. Before 37, it's preterm. After 42, postterm. Simple. Now, what is normal birth weight? 2.5 to 3.9. 2.5 to 3.9 kg is the basic birth weight. When we use the word low birth weight, if weight is less than 2.5 kg, it's low birth weight. When weight is less than 1.5 kg, very low birth weight. You need to understand, MCQ is there. When we use the word extreme low birth weight, when weight of the baby is less than 1 kg. So clear, term, preterm, postterm. Normal weight, low birth weight, very low birth weight, extreme low birth weight. What is perinatal period? Perinatal period is defined as 22nd week of gestation till less than 7 days of life. So these all basic definition you need to remember. What is neonate? Term, postterm, preterm. Normal weight, low birth weight, very low birth weight, extreme low birth weight, and what is perinatal period? From in utero 22nd week to 7th day of life is perinatal period. So after that, we know few fact about neonate. What is the normal birth weight? 2.5 to 3.99. What is the height of the neonate? 50 centimeter. Till 2 years of age, we take the length. After 2 years, we take the height. Okay, so this 50 centimeter is the normal. Yes, it will help you when we solve the questions. So normal weight 2.5 to 3.99. Normal length or height 50 centimeter at birth. Head circumference 33 to 35 centimeter at birth. Normal for a term baby. Now, at birth, HC is always greater than CC. Head circumference is always greater than chest circumference at birth. At birth, how much? By 3 centimeter. How height change, how weight change, head circumference change with different ages, we will discuss in growth and development. First, you remember these basics. Yes, HC and CC equal by 1 year of age. At 1 year, HC is equal to CC, and after 1 year, chest circumference is always more than head circumference. Now, upper segment, lower segment ratio. What is upper segment? What is lower segment? Now, this is the total height of a baby, total length of the baby. We put a point over pubic symphysis and take down. So, this is lower segment, this is upper segment. Ratio of upper segment to lower segment in a neonate is 1.7:1. How this ratio changes, we will discuss later in short stature. Okay, so these are the basic thing. What is the basic weight at birth? What is the normal height? What is the normal HC? What is upper segment, lower segment ratio? Now, one most important point. Normal baby passes stool within 24 hours. Within 24 hours. You can't panic. 18-hour baby don't pass stool. No problem. Upper limit is 24 hours. Baby pass urine within 48 hours. Yes, stool A, B, C, D, S come first. Stool baby pass first, then urine U. Stool within 24 hours, urine within 48 hours. It's look like very simple. Na? When MCQ comes, na, this simple line create a great meaning. Great meaning. Now, umbilical stump usually fall 3 to 15 days of life. if you saw a baby in the OPD, umbilical stump is still there. So, delayed separation of umbilical stump is indicate that we are dealing with leukocyte adhesion defects. Now, do you remember all the lines? When the MCQ comes, then its importance comes. So, normal weight 2.5 to 3.99, height 50 centimeter, HC 33 to 35 centimeter. At birth, head circumference is always greater than chest circumference by 3 centimeter. Upper segment to lower segment ratio at birth 1.7:1. Normal baby pass stool within 24 hours, urine within 48 hours, umbilical stump fall 3 to 15 days of life. If delayed falling more than 45 days, suggest leukocyte adhesion defect. Now, weighing scale you have all seen how we take the weight of a neonate. But what is this? Infantometer. To take the length, to take the height of the baby. Toe end fix at one side, head another side, stretch the baby. This indicate normal length of the baby. So, length instrument used to take length of the baby is infantometer. So, till now neonate birth to 28 days, term 37 to 42 week, preterm less than 37 week, postterm more than 42 week. Normal weight 2.5 to 3.99, low birth weight less than 2.5, very low birth weight less than 1.5, extreme low birth weight less than 1 kg. Perinatal period 22nd week of gestation till 7 day of life. Normal weight 2.5 to 3.9, height 50, HC 33 to 35, upper segment, lower segment 1.7:1, normal baby pass stool within 24 hours, urine within 48 hours, umbilical stump fall 3 to 15 days of life. If delayed separation, say 45 days, a suggestive of leukocyte adhesion defect. Infantometer used to measure length of the baby. Now, apply. Read this question. This is the meaning, na? You read and do the question. Mother was worried her child not pass urine on postnatal day 1. Means still 24 hours is there and baby not pass urine. Are you worried? Are you worried? No, because you know the basic. Normal baby pass urine till 48 hours. No worry till 48 hours. First day urine nahi hua? No worry. So, what we will do? Start formula milk? No. Start IV fluid? No. Admit in ICU? No. It's a normal finding. Baby can pass urine 26 hours, 30 hours, 36 hours. It's a normal finding. Upper limit of urine is 48 hours. Till 48 hours, no worry. So, continue breastfeeding and observe is the right answer. So, this is the way we know the basic fact and do the related MCQs. Now, vital sign. What is the normal heart rate, normal respiratory rate and normal temperature in a neonate? Heart rate in a neonate is 110 to 160 per minute. Respiration is 40 to 60 per minute and temperature is 36.5 degree to 37.5 degree centigrade. These are the vital signs. We should know neonate heart rate more than 160, we use the word tachycardia. Respiratory rate more than 60, we use the word respiratory distress. Temperature less than 36.5, hypothermia. So, these are the vital signs you should remember. So, till now we are reading just basic, but yeah, now the real thing comes which you need to understand. What is SGA? What is AGA? What is LGA? Simple. SGA, small for gestation age. AGA, appropriate for gestation age. LGA, large for gestation age. So, what is meaning of SGA? If weight of the baby is less than 10th centile for that gestation age, SGA. Weight of the baby is between 10 to 90th centile for that gestation age is AGA. weight of the baby is more than 90th centile for that gestation age is LGA. Definition is simple. SGA, weight is less than 10 centile. LGA, weight is more than 90th centile. AGA, weight is 10 to 90th centile. It's simple. But what it means? Listen. Suppose a baby born at 39 week. Weight of the baby is 3 kg. So what you will write? 39 week, it's a term baby. Weight is 3 kg. So we should know for a term baby what is the meaning of 10 centile and what is the meaning of 90th centile. 10 centile is 2.5, 90th centile is 3.99. Weight of the baby is between 2.5 to 3.99. So what is this? This is term but AGA. Second example, a baby delivered at 39 week, weight 2.1 kg. Now, we need to write complete diagnosis. Term means 39 means it's term. But for term, what is the value of 10 centile? 2.5. What is in our case? It's 2.1. So, what is this? Term but SGA. Clear? Another example, baby born at 38 week. Weight of the baby is 4.5 kg. Now you can understand it's term but it's LGA. So, we need to see weight of the baby is less than 10 centile for that gestation age is SGA. When gestation age is term, for term baby, if weight is less than 2.5, it's SGA. Term baby, weight is more than 4 kg, it's LGA. Term baby, weight is between 2.5 to 3.99, AGA. One more example, you will better understand. A baby born at 32 week. Weight of the baby is 1.5 kg. Now we need to write complete diagnosis. 32 week means it's preterm. Clear? Now, you may be wondering what we use in this case, SGA, AGA or LGA. You must be wondering. So, for that case, we should know 10 and 90th centile for 32 week. So, 10 centile for 32 week is 1.2, 90th centile is 1.8. Weight of the baby in between 1.2 and 1.8. So, it is AG. Suppose this baby weight is 1.1, 32 week weight is 1.1, preterm but less than 10 centile for 32 week. So, it is preterm but SGA. Means we need to remember 10 and 90th centile for every gestation age? No, my friend. This is for your understanding. See here. Whenever baby born comes in the nursery, we have this curve. So, here is the week in gestation. Here is the weight of the baby. So, we mark, suppose it's 39 weeks. So, we mark 1 point here. Suppose baby weight is 2.8. We put 1 part mark here and we join these two both part. So, it's come between 10th and 90th centile. So, this baby is AGA. Suppose baby born at 39 week and weight 4.5 kg, then it goes like this. More than 90th centile. The term baby we can easily understand. For preterm also, see baby deliver at 32 week. Weight of the baby is 1.5 kg or 1.7 kg. 1.7 for 32 week comes between 10th and 90th centile. So, it is AGA. Suppose baby born at 32 week but weight is 900 gram. So, this baby is preterm also SGA. Also SGA. You got my point? Weight of the baby is less than 10 centile for that gestation age. Whatever the gestation is of the baby, we mark here. Weight, we mark here. If it's come below 10 centile, it is SGA. If it's come above 90th centile, it is LGA. If it become 10 and 90th centile, AGA. Clear? Now, SGA is of two types. Asymmetrical, symmetrical. SGA is of two types. Asymmetrical have 3 points. Symmetrical have 4 points. Now try to understand. Asymmetrical, SGA. A baby born at term, weight 2 kg. It's 2 kg. Weight is 2 kg. Okay. So now you can feel this is SGA. This is SGA. Whether it's asymmetrical or symmetrical, for that what we will do? Asymmetrical, insult occur in later part of pregnancy. Insult occur in later part of pregnancy. Only weight reduce. Suppose we have previous antenatal records of the sonography. So, 12th week of pregnancy, baby weight is 600 gram. 18 week of pregnancy, baby's weight is 1.2 kg. 24 week of pregnancy, baby weight is 1.8 kg. And 32 week of pregnancy, baby weight is 2.4 kg. Baby weight is 2.4, means growing very well. Suppose 12th week, 18 week, 24 week, 32 week, weight 600 gram, 1200 gram, 1800 gram, 2400 gram. 32 week, 2400 gram. Another 6-7 week still in utero, baby will cross 2.5 kg and it's turned out to be normal birth weight and AGA baby. What happened at 32 week? Mother develop hypertension. Because of hypertension, there is a uteroplacental insufficiency. Further weight gain not there. Further weight gain not there. At 39 week, we did a cesarean and 2.4 kg baby comes out. 2.4 SGA. But we know everything is fine till 32 week. It means afterward some problem is there. So, insult occur in later part of gestation. First point. Number 2, only weight reduce. For this baby, height, head circumference, chest circumference, everything will be fine. Only weight is reduced. Only weight is reduced. Now, third point we will discuss later. Symmetrical IUGR. Insult occur in early part of pregnancy. 12th week of pregnancy, 18 week of pregnancy, 24 week of pregnancy, 32 week of pregnancy. 12 week weight is 400 gram, 18 800 gram, 24 1200 gram, 32 1600 gram and 39 week normal delivery 1.9 kg baby delivered. So, problem is from the beginning. From beginning there is no weight gain. Insult occur in early part of gestation and we know early part of gestation is a period of organogenesis. So, all parameters are reduced. Weight, height, HC, everything will be reduced. And if insult occur in the early part of gestation, this baby is prone to develop congenital anomaly. Now, these two are okay. Now, you are posted in nursery. Night 2 o'clock, you receive a call. Doctor, please come. We have a urgent normal delivery or cesarean. They need your help. You went there. Baby delivered. Cries immediately after birth. You did the initial step of resuscitation. Drying, stimulate, clear the airway, mouth, nose, everything. Now, when take the weight of the baby, it shows 2 kg. Gestation wise, baby is term, but weight is 2 kg. So now you know term 2 kg, it is SGA. Now you are more intelligent. You want to know whether it's asymmetrical or symmetrical. You ask from ops resident, ma'am, I want the previous sonography record if any sonography is done. They come first time to the emergency in full dilatation, delivered within half an hour. So no antenatal record. Then how can you identify it's asymmetrical or symmetrical? How can you identify it's asymmetrical or symmetrical? No, this check the antenatal sonography record. This example I just gave you to build the concept, insult occur and early or late. For all those things, we calculate ponderal index of the baby. If ponderal index less than 2, it's indicate asymmetrical IUGR or asymmetrical SGA. If ponderal index is 2 or more than 2, it indicate symmetrical IUGR. Now, what is ponderal index? Weight in gram upon height in centimeter cube into 100. So, it's a normal practice. We not check the antenatal record in the weight in the sonography. Just take the weight of the child, height of the child, put this formula and you get the value. Okay, you will get the value. If value is less than 2, then it is asymmetrical. 2 or more than 2, then it is symmetrical. Now, this also no need to remember, you can very well understand. Suppose 20 by 10, this is the figure. Now, if we decrease numerator only, 18 by 10, 16 by 10, 14 by 10, definitely value will less than 2. But numerator and denominator both get reduced. If 20 become 18, 10 become 8. If 18 becomes 16, 8 becomes 6. 16 become 14, 6 become 5. Got my point? Numerator and denominator both reduce, resultant value will be more. Same thing happen. Ponderal index is the ratio of weight and height. What happen in asymmetrical IUGR? Only weight reduce. What happen in symmetrical IUGR? Weight and height both reduce. When weight and height both reduce, resultant value will be more than 2. More than 2. Clear? Clear? Now, SGA. We use the word SGA when weight of the baby is less than 10 centile for dead gestation age. SGA is of two types, asymmetrical and symmetrical. Asymmetrical. Insult occur in later part of pregnancy. Only weight reduce. Ponderal index less than 2. Symmetrical. Insult occur in early part of pregnancy. All parameters are reduced. Prone for congenital anomaly and ponderal index 2 or more than 2. Simple, simple. Now, simple question. Now, ponderal index of a child, weight 2 kg, height 50 centimeter. This happen in the exam. We forget what's the formula. Weight in gram or kilogram. We forget. But yeah, weight in gram. So it is 2 kg. So 2 into 1000. It will come gram. Height 50 centimeter cube into 100. Now simple maths. 10 10 10 10 10 10. It become 200 by 125. Answer will be 1.6. 1.6. Now, suppose your attitude should be, we need to do the question. We need to do the question. Here comes the basing, your approach. You forget the formula of ponderal index. But what you remember, What you remember? Ponderal index is less than 2 in asymmetrical and ponderal index is more than 2 in symmetrical. Read the question. Weight is 2 kg, definitely reduce. Height is 50, that is normal. What is asymmetrical? Only weight reduce. Only weight reduce, height normal. So, I do not know the correct answer, but whatever the answer, it is below 2. So, this you can rule out, this you can rule out. Then, if you want to do it, yes, do it, because 50% chance you may get a correct answer. So, choose your answer between 1.6 to 1.8, but if you know the formula and proper calculation, your answer would be 1.6. Am I clear? Am I clear? SGA, asymmetrical, symmetrical, Ponderal index, lot of questions are there in exam. Simply they ask about what is the formula of Ponderal index. Sometime weight, height, calculate the Ponderal index. All are true about asymmetrical IUGR. All are true about symmetrical IUGR. We will do the application based question, don't worry. But these are the fact. Now, what are the problems if a preterm baby 30 weeker, 28 weeker comes in the nursery? What are the problem you are expecting? And what if a term baby 2 kg, 2.2 kg, you know this is SGA. What are the problem in that baby you are expecting? Lot of MCQs, lot of clinical things. A preterm baby comes to the nursery, first thing comes in your mind, hypothermia. Yes, there is a brown fat which generate heat in the neonate. But preterm, no brown fat, less brown fat. So, they are prone for hypothermia. So, preterm care always done in tertiary care center, where proper radiant warmer is there because they are prone for hypothermia. In our MD days, neonatology is not so much advanced. We get very few radiant warmer in our NICU. Now 100 radiant warmers are there. But that time only 1 or 2. So, generally we wrap the neonate in the cotton or put them preterm baby in front of bulb. Yes, hypothermia. Then hyperbilirubinemia. Why? In subsequent class we will read liver and gut are immature. So, preterms are more prone to develop hyperbilirubinemia. HMD we will read. Yes, definitely any baby born before 35 week of gestation prone for HMD. Apnea, cessation of respiration for more than 30 seconds, apnea. Yes, preterm brain stem is immature. So, chance of apnea is more. NEC, necrotizing enterocolitis, ICH, intracranial hemorrhage, they are prone for sepsis. Each and everything, why this happen, we will read in subsequent sessions of neonatology. NAC, HMD, jaundice, all that we will read. But these problems are more common in preterm babies. Suppose a term baby 2 kg, you know, term 2 kg means SGA. What are the problem in SGA you are expecting? They are prone for hypoglycemia. Check the sugar before sending the baby out of the nursery. Hypocalcemia. Polycythemia, it's not anemia. By mistake, we think SGA, intrauterine growth retarded. Sugar come, calcium come, maybe hemoglobin also less. No, because of uteroplacental insufficiency, baby growth not well in utero. Hypoxic condition is there. Whenever hypoxia is there, erythropoietin level is more. So, SGA, they have polycythemia, not anemia. Now, you are practicing neonatologist or practicing pediatrician. You receive a call at night, 12 o'clock. At night, 12 o'clock, midnight. Doctor comes, we are taking urgent cesarean. The first question you will ask, what's the urgency? Reply come, sir, it's SGA baby, IUGR baby. Term, but weight is 1.8 kg, 1.9 kg. You need to rush. Why? Why? See, that baby is 1.8 kg, not growing well. Why? Because of uteroplacental insufficiency. Uteroplacental insufficiency, growth is not happening. So, whenever there is a uteroplacental insufficiency, fetus, baby inside is in distress. Baby may pass meconium during delivery or before delivery. So, you may get a meconium stained baby which require active resuscitation. So, you need to go IUGR baby, SGA baby, meconium aspiration syndrome. Uteroplacental insufficiency, baby in hypoxic condition, it may possible, hypoxia persist, so maybe birth asphyxia, baby not crying after birth, it need active resuscitation. Like preterms prone for ICH, SGA prone for pulmonary hemorrhage. Because if meconium is stained, baby take the meconium inside, it leads to chemical pneumonitis, lot of changes in the lung, we will read in the subsequent sessions, pulmonary hemorrhage, and finally prone for congenital anomaly if it is symmetrical SGA. So, suppose the baby is term with 1.8 kg weight, SGA, symmetrical SGA, symmetrical. So, just auscultate the baby and for any murmur, just palpate the abdomen for any lump, just see the back for any lipoma or any tuft of hair or any growth or any dimple. Look at the extra digit, look at the cleft palate and lip. They are prone for congenital anomaly. So, question come on this. Now, I gave you the concept. What is SGA? What is LGA? What is AGA? Symmetrical, asymmetrical. Ponderal index. Problem in SGA, problem in preterm. Now, LGA. Large for gestation age. Weight of the baby more than 90th centile. More than 90th centile. Okay. Term baby 4.8 kg, 4.5 kg. This is LGA, large for gestation age. If a baby born LGA, what are the things come in your mind? Just remember those few things and some rare syndrome. It will definitely help you in MCQs. Okay, LGA, number 1, constitutional. Number 2, infant of diabetic mother. Number 3, TGA. Number 4, erythroblastus fetalis. Constitutional, mother and father both are overweight, both are 95-96 kg, baby weight will be also more. Infant of diabetic mother, I will explain you. Infant of diabetic mother, there is a more insulin. We will read this topic, infant of diabetic mother, more insulin, and insulin is required for growth of the fetus. So, infant of diabetic mother, birth weight is always more. Babies are LGA. TGA, transposition of great arteries. When I teach you cardiology, fetal circulation, then I will explain you in TGA why baby is LGA. Erythroblastus fetalis, RH incompatibility, severe hemolysis, anasarca, edema is there. So, remember these 4 causes specifically for LGA: constitutional, infant of diabetic mother, TGA and erythroblastus fetalis. Then remember few rare syndromes, but not so rare, they come in exam. Beckwith-Widman syndrome, Marshall-Smith syndrome, Soto syndrome. Soto syndrome, another name for Soto syndrome is cerebral gigantism. Cerebral gigantism. So, this is the teaching. Try to understand the concept and remember the thing itself in the class. I will repeat everything in 1 minute. You need to concentrate again. First, basic definition. Neonate from birth to 28 days. Term 37 to 42 week, preterm less than 37, postterm more than 42. Normal birth weight 2.5 to 3.99. Revise. Low birth weight less than 2.5, very low birth weight less than 1.5, extreme low birth weight, yes, less than 1 kg. Perinatal period 22nd week of gestation to less than 7 days of life. Okay, normal weight 2.5 to 3.99, height 50, HC 37 to 35, upper segment lower segment ratio 1.7:1. Baby pass stool within 24 hours, urine within 48 hours, umbilical stem fall 3 to 15 days of life. If delayed falling, suggestion of leukocyte adhesion defect. Clear? Vital sign. Heart rate 110 to 160, normal for a neonate. Respiratory rate 40 to 60, temperature 36.5 to 37.5 degrees centigrade. SGA, AGA, LGA, definition clear. SGA, two type, asymmetrical, symmetrical. Asymmetrical, insult occur in later part of pregnancy, only weight reduce, Ponderal index less than 2. Symmetrical, insult occur in early part of pregnancy, all parameter reduce, prone for congenital anomaly, Ponderal index is 2 or more than 2. Ponderal index, weight in gram, height in centimeter cube into 100. LGA, constitutional, infant of diabetic mother. TGA, erythroblastus fetalis, Beckwith-Widman syndrome, Marshall-Smith syndrome, Soto syndrome. Clear? Now, the things clear, it will be more clearer if we do the MCQ. So, concentrate and do this MCQ. SGA babies are predisposed to develop following clinical problem. SGA ka chart just remember in your mind: hypoglycemia, hypocalcemia, polycythemia, meconium aspiration syndrome, birth asphyxia, pulmonary hemorrhage, congenital anomaly. Hypoglycemia is there in SGA, pulmonary hemorrhage there in SGA, meconium aspiration syndrome there is SGA. It's not anemia. Not anemia. SGA babies is having polycythemia. SGA baby is having polycythemia. Clear na? Answer this question. If you have a clear concept na, what is SGA, what is asymmetrical, what is symmetrical, then it's very easy. And when we learn the text and do this type of MCQ, concept are more clearer. Which of the following condition can cause asymmetrical growth retardation? Asymmetrical means insult occurring later half of pregnancy. Trisomy 18 is problem in chromosomes. Trisomy 18, Edward syndrome. It is from the beginning, na? It is present from early part of pregnancy. CMV infection, if causes anything wrong in the fetus, from early part of pregnancy. Fetal alcohol syndrome. A pregnant lady consume alcohol particularly in the first trimester, early part of pregnancy, then it leads to problem early. But preeclampsia is the manifestation of late pregnancy. So, if mother is hypertensive, hypertension leads to uteroplacental insufficiency, baby become IUGR. So, asymmetrical insult occur in the later part, it is preeclampsia. Okay. Now, this is a real check question for you. Concentrate. Try to do this question for yourself. If you are able to solve this question, yes, you are on the right track. It's require memory and little bit application. I will explain you after 30 seconds. Then you will say, oh, it was so easy. Yes, you got it, or you miss it after 30 seconds. Concentrate. Yeah. 2 infants born at 37 week of gestation. 37 means it's a term. Infant A weigh 2.6 kg. Infant B weigh 1.6 kg. Now, term baby weight is 2.6 AGA. term baby weight is 1.6. This baby is what? SGA. If you pick this in the question, and you are able to pick this only if you know the concept of SGA. You pick, this is SGA, you pick it, this is SGA. Now this question is as simple as our previous question. Means infant B is more likely to have all of the following problem except aspiration pneumonia, hypoglycemia, congenital malformation, low hematocrit, no anemia. So this question and this question is the same. In this question they are asking directly, all are occur in SGA except anemia not occur in SGA. This question they are asking indirectly, what problem occur in baby B. The first thing you need to pick that baby B is SGA. Baby B is SGA. You need to pick baby B is SGA. And then question become very simple, my friend. If you put it right, just feel good, okay? Because it's clinical based, application based question. Yes, if not put it right, yes, we are here for learning, na? Just read the question properly, A and B. B is SGA. Now they are asking what problem occur in baby B. It's not low hematocrit, it is polycythemia. The concept, basic definition, SGA, LGA, those questions, those concept is clear. Move forward. Minor clinical problems. There are few clinical problems, they are minor. Most of them require no treatment, but yes, little attention, like phimosis, vaginal bleeding, breast engorgement, Epstein pulse, melia, lot of Mongolian spots. Now, trend of image based questions are there. So they ask you frequently in the exam these minor problems. Examiner asks frequently with the diagram. We know everything about those problems. It will take just 5 to 10 minutes. Okay. Just have a feel, do this question. Comes in previous exam, both for FMG and NEET-PG. Just read this question. If you are reading first time, you feel little bit, yeah, maybe. But if you done this, it's very easy question. Appropriate approach for a female neonate presented with vaginal bleeding on 6th day of life. Vaginal bleeding on 6th day of life. Vaginal bleeding on 6th day of life. What you will do? Administered vitamin K? No. Bleeding disorder? No. FFP? No. No specific treatment needed because it is a normal finding. Vaginal bleeding in a female neonate till 2nd to 3rd week of life considered to be normal finding. It is due to withdrawal effect of maternal estrogens. So this is normal finding. So yes, it is normal. So there are so many things which are normal findings, not need any treatment, but we should know. Else, 6 days old female having vaginal bleeding, if parents are not aware of those things, they become panic. Okay. These all we will read. Melia, erythema toxicum, Mongolian spot, Epstein pulse, breast engorgement, predecidual teeth, vaginal bleeding, phimosis, cephalometoma and caput succedaneum. It will take 5 to 6 minutes. Now, just 30 seconds, watch all these pictures. Just for 30 seconds, watch all these pictures. Just for 30 seconds. white bump over face, sometime at the nose, these are melia. These are normal finding. Present second to third day of life, disappear within 2 weeks. They are keratin filled material, require no treatment. You may find these melia in 50 to 60% of normal term neonate. Melia. You just remember this picture, white bump over face and nose filled with keratin. This is the rash. Central white, red surrounding, erythema toxicum. If you are seeing neonate, this is very common, erythema toxicum. There was one question in detail. If you scrap this erythema toxicum, you scrap this, eosinophil will show. In the PBF, eosinophil will show. This is Mongolian spot. Very common. Examine the neonate. Back, trunk, you will find bluish discoloration patches. Those are known as birthmark, Mongolian spot. It's not related to Mongol. It's not related to Down. It may present in a normal neonate. Commonest site for Mongolian spot is lumbosacral region. Lumbosacral region. Now, if you examine the throat, palate, because you need to examine the palate because child may have cleft palate. When you examine the palate, you find white color dot in the center. Epstein pearl. Epstein pearl. What? It is the entrapment of epithelium at the time of palate fusion. Entrapment of epithelium at the time of palate fusion. So, there are few MCQs. Erythema toxicum scraping shows eosinophil. Mongolian spot, commonest position is lumbosacral region. And Epstein pearl filled with keratin. And all those are normal finding. No treatment is needed. But you need to identify these are normal. So, see the picture again. Melia, erythema toxicum, Mongolian spot, Epstein pearl, normal. You may find all these in 50 to 60% of normal neonate. Require no treatment. Require no treatment. And these are the MCQ. Erythema toxicum scraping shows eosinophil. Mongolian spot, commonest position is lumbosacral. Epstein pearl filled with keratin. Few more. Here are you. Watch. You are finding something here. Teeth. Neonate born with teeth. Natal teeth. First teeth to erupt in a neonate is lower central incisor at 6 to 8 months of age. But neonate is having teeth. Neonate is having teeth. What are the causes? What are the causes? Write down. Ellis Van Creveld syndrome, Pierre Robin syndrome, Hallerman Stariff syndrome, Rubinstein Tybee syndrome. Simple. Ellis Van Creveld syndrome. It's simple. When I was appearing for my MBBS exam, this question asked to me by examiner, any condition in which neonate born with teeth, Ellis Van Creveld syndrome, Ellis Van Creveld syndrome. Guys, subsequent edition changes. In our edition, this is mentioned in the book. Ellis Van Creveld syndrome, Pierre Robin syndrome, Hallerman-Streiff syndrome, Rubinstein-Tybee syndrome. Yes, when we are reading something additional also, it's not rare, my friend. You may find a question in neonate with teeth. Which of the following syndrome you can suspect, Down, Turner, Ellis Van Creveld, like that. Image based question. Yes, these 4, Ellis Van Creveld syndrome. Remember, Pierre-Robin syndrome, Rebestin-Taibi syndrome, Hallermann-Streiff syndrome. Just remember, for repeat all these, just write their name. It will take 30 seconds for you to remember it all and over. Clear? Ellis Van Creveld, Pierre-Robin, Hallermann-Streiff and Rubinstein-Taibi syndrome. Now, see the phimosis, it's very common. Normally what happen? This is penis, foreskin, cover the glans. Foreskin cover the glans. Inability to retract foreskin over the glans, it's phimosis. So, generally, neonatologists advise mother, when they give bath to the male child, just try to retract prepuce over glans. Few days she is not able to retract because few adhesion is there. It's a physiological phimosis. But gradually it come. Okay, physiological, so minor problem, no treatment is there. But if it's pathological, needs circumcision. Phimosis. Now, swelling overhead. In labor posting, you may say live this caput and cephalohematoma. So, question comes, caput and cephalohematoma, you need to know the difference. Caput succedanum can extend across the suture. This is the most important point by which you can differentiate. It's a boggy swelling, can extend beyond the sutures. Okay, but cephalohematoma usually over parietal bones that do not cross the suture. By this is the best thing we can differentiate. And second point, caput succedanum resolve within 48 to 72 hours, but cephalohematoma resolve over 2 to 3 weeks. 2 to 3 weeks. 2 to 3 weeks. Okay. Cephalohematoma, if significant bleeding occur, it may severe rarely. But these 2 points, caput crosses the suture line, disappear in 2 to 3 days. Cephalohematoma, it's take 2 to 3 weeks to resolve and never crosses the suture line. Never crosses the suture line. So, these are minor problem, neonatal teeth, phimosis, caput and cephalohematoma. Melia, erythema toxicum, Mongolian spot, Epstein pearl. These days, every exam, image based questions are there. You may find an image of a neonate with teeth. Which of the following syndrome is there? That's why these things are important, because of image based question, because these are normal neonatal finding which require no treatment. But this is you should know. This is you should know. Minor clinical problem. Yeah, see the baby. If you are posted in nursery during your intern or house job, you may find this picture once in a month. What you are expecting in this baby? Yeah, watch carefully. Half skin color is different. Half skin color is different. And this is a normal finding. Normal finding. Harlequin color change. Harlequin color change. See, this can come in your exam. This picture is there. It is due to temporary imbalance in vascular tone of cutaneous blood vessels due to hypothalamus immaturity. No treatment is needed. You are seeing at 12 o'clock, sir, this change is there. You call your senior or junior to watch. By the time they arrive, it may disappear. It is temporary imbalance in the vascular tone of cutaneous blood vessels. It's normal finding, but it can be associated more commonly in a preterm baby and baby on prostaglandin infusion. Prostaglandin infusion, that may come as a MCQ, image based question, minor clinical problem, milia, erythema toxicum, Mongolian spot, Epstein pearl, caput, cephalometoma, phimosis, natal teeth, vaginal bleeding, breast engorgement, Harlequin skin changes. These are normal, my friend. Yes, we will read, definitely we will read. Torch, jaundice, HMD, that's the real neonatology. But yeah, this is the basic definition. Then move to SGA, AGA, LGA, asymmetrical, symmetrical, Ponderal index, LGA's example, forget. Constitutional, infantile diabetic mother, TGA, erythroblastus fetalis, Beckwith-Widman syndrome, Marshall-Smith syndrome, Soto syndrome. My friend, this is the fun, na? Yeah, you are watching me recorded. So yes, make some effort. I will try my level best to keep you engaged in the class. Some text, some question, again repeat. Try to memorize the things with that in the class. So this is basic. Many more comes in the neonatology. Yes, we will read subsequently about respiratory problems, HMD, neonatal feeding, jaundice, torch, infantile diabetic mother, hemorrhagic disease of newborn, many more to come. And finally, neonatal resuscitation. Yes, so this is basic neonatology. Yes, we will start second session soon. Thank you. Keep watching.